First of all, welcome to the Royal Free. This is the second time we've hosted one of these PSC support meetings. Massimo Pinzani, who's our academic lead, so he's the director of the UCL Liver and GI Research Department, sends his apology. He's recently sustained quite a significant back injury, and he's had a recurrence of problems. He'd broken a bone, and so he called me. He was due to come this afternoon to say hello, say a few words, but he sends his apologies, but he also welcomes you to UCL and the Royal Free. So the topic that I'm covering this afternoon is to talk a bit about the research that's going on at the moment in PSC. And there were three kind of headlines that I was given from Martine to talk about. One was the UK-PSC project. The other was the quality of life measure that Martine mentioned. And the other thing which I would expect would be of particular interest to you is current clinical trials that are open or potentially opening it over the next short while. So this is just a list of questions that came back from the PSC support survey that was undertaken in 2014. Questions that PSC patients or PSC or relatives of PSC patients would like answered. And I think they're all fantastic questions, and I would love to say that we were able to answer these questions in 2014 or even in 2015. But unfortunately, many of these questions remain to be answered. But as Martine mentioned, there is a lot of work and an increasing amount of work and a much more organised plan for the research that's taking place around PSC. And I hopefully will reassure you and excite you about the possibilities in PSC research. So I think one of the problems in PSC research in the past is that the disease is relatively rare. So while interested centres like here and some of the other centres in the UK might have cohorts of reasonably significant numbers of patients, so a few hundred patients, it's not really enough patients to kind of answer some of these more difficult questions. And so what's really been needed is large cohorts of patients. And then also we need to better understand the nature of the disease. Is it one disease? Is it a collection of several different diseases that have similar characteristics but are fundamentally not the same disease? Because it may be that there are different treatments that are relevant for each of the different types of disease. We also need to know where in the natural history of the disease people are, because if you start a treatment in somebody with very advanced disease, while it may be an effective treatment earlier on in the disease, it may be ineffective late in the disease. And also if you are comparing two groups of people and treating one group with one drug and not treating the other group, if those two groups are at different stages of their disease when they're treated, it may look like the drug works or doesn't work. And in fact, it's just because the two groups that were being treated were at different stages of the disease. So it's really important that we better understand where individual patients are in their disease for the sake of research, but also for the sake of the individual patients that we have conversations with, because that's one of the questions that we're most frequently asked when we see patients in clinic is, how am I doing? You know, what's going to happen to me? We can quote numbers, but it's very difficult to predict for individual patients what the outlook is. And then the next thing is that we need to have endpoints for trials. So I'll mention a little later, but the best outcomes to demonstrate something works are improvements in survival, because that's effectively what you're wanting to achieve. And in the case of PSC, it's around transplant-free survival, so about people surviving without needing a transplant. But because of the long natural history of PSC, it's very difficult to expect that a study is going to run for long enough that you can actually demonstrate that you can have an impact on those sorts of outcomes. So what we need to find are better markers of response to treatment, which you can pick up on earlier, and means that you don't have to wait the several years until people develop a complication of their disease. And then the final things are you need to have the right treatments, or you need to have potential treatments, and you need to have well-designed trials to to look at them in. So in terms of the addressing the first couple of questions, that's where UK-PSC has really come into its own. It's the first significant consortium around PSC. The International PSC Study Group began in 2010, but this was developed with the foresight of a chap called Graham Alexander in Cambridge, who now works here at the Royal Free and also still in Cambridge. And the proposal was to develop a study to look at the genetics of PSC. And it was a tremendous success. Over 200 hospitals in the UK have participated, and as you can see there, these figures are now a little out of date, but there's probably about 2,500 patients with PSC that have actually participated in the study, and that's the one that Martine was discussing, that you and many of you expect to have done it, to provide a sample of saliva or possibly a blood sample, and these samples are then sent to Cambridge. But one of the difficulties of that, or the limitations of that study when it was designed, is the issue that Martine is suggesting this portal might help get around, is that it really is a moment in time assessment. There's not really any follow-up of the patients. It was just a sample provided, a questionnaire completed, and while that was that is an amazing resource. It's not really providing us the longitudinal follow-up of people with PSC, but it provided a perfect foundation for PSC research. And you know, the UK has really been in the forefront of that. So I have to credit Graham Alexander with a lot of vision in that respect. And then at the end of, I lose track of time, but I think it was at the end of 2014, Gideon Hirschfield from Birmingham got a group together and put in a submission to try and get additional funding from NIHR, from the Rare Diseases Consortia that Martine mentioned as well, and that application was successful, and that was to take the UK-PSC to the next stage, project to the next stage, which was more about prospectively following some patients and also providing a much deeper assessment of individual patients, or a subset of individual patients with PSC. And from that submission, the rationale was it was to try and better understand the basics of the disease, try and help with this issue about surrogate markers or earlier predictors of response to treatment, trying to separate out if it's different diseases, and also by having a large number of patients who we've got a lot of detail on, it means when new treatments become available or new trials become available, it becomes much easier to identify those individuals that might be suitable for trials and at least give them the opportunity to be involved, whether they choose to take that up or not. As I say, there's the original UK-PSC genetics study, but that's now been followed up by this follow-up study. And from that master cohort of over 2,500 patients, the plan is to take 1,000 people and look into them in much greater detail. And then investigating this question as to whether this is a collection of different diseases. The idea was to look at specific varieties of PSC to see and look at smaller groups of patients, around 50 patients with each of these types of disease, to see if by looking at them in much greater depth immunologically and with imaging, etc., whether they were actually different diseases. And that's people with younger onset, which is often people that develop the disease younger. It's got the disease has got more features along the lines of autoimmune hepatitis rather than just pure PSC. Those 10 to 20% of people that develop carcinoma, or those people that develop colonic cancer or dominant bile duct strictures, the people that develop small duct disease, which seems to have a better prognosis, the 20% of people that, or 20 to 30% of people that don't have any inflammatory bowel disease, and then there's also the group of patients that have a high IgG4 level, which is supposed to be associated with a worse outlook. So the idea is to try and hone in on individuals with these characteristics, and then look at them in much greater detail to see if what we can glean from them, and see if we can identify whether these subsets of disease are truly different. And the idea is that we'll continue to have the majority of hospitals recruiting patients into this large database, and then there'll be hub centres that will recruit patients for the more deep phenotyping aspects, which would involve non-invasive assessment using lots of different tests, but also samples of urine, stool, and blood for more detailed testing. And the rationale is to produce this very evolved, research-ready structure, which will mean that when clinical trials come along, patients can access them as well. So try and answer questions, but also be ready when companies are looking to evaluate their new treatments and they're wondering where they'll go. They'll always choose to come to the UK because we can guarantee that we can access the patients that will be potentially suitable for the trials, and then obviously it's up to the patients to decide and their families to decide if they want to be involved in the trials. But at least we'll be in a position where the UK will be at the forefront of that, and it's really it's an ambition, but I think it's quite a straightforward ambition to deliver. So the main hub sites are listed here, and the ethics are just going through for this second phase of the UK-PSC project, and I expect that once we get into maybe springtime of next year, you may be getting contacted to be involved again. So that's really just to sort of outline where the UK-PSC project is. So as I say, once we've got the cohorts of patients, and we've got more understanding of the disease from projects like the one that I've described, the next thing we need to do is to be able to understand the severity of individual patients' disease. So the reason I say this, and I'm sure you understand, and you'll know yourselves if you have PSC or if you have a relative that has PSC, one of the great problems is to know where on this sort of trajectory of any disease somebody is with PSC. People can be well, or they can have significant symptoms. The symptoms often don't relate to how severe the disease is. So how do we know where people are? And it's not just where they are in a moment in time, it's just whether individuals have a worse trajectory of disease than somebody else. And that's something that we haven't really managed to get a handle on up until now. And so there are a few means by which we try and identify people that have that we think are less likely to have problems. So we've already mentioned people with small duct disease. So this is cholangiography is just pictures of the bile ducts. So if there's no big bile ducts that are involved, people tend to have a better outlook. And if the alkaline phosphatase, one of the blood tests I expect you'll have heard of, if that level is normal or low, then people tend to have a better outlook. But there's also increasing evidence that the stage of fibrosis that there is within the liver. So one of the things about PSC is that I don't know how many of you that are affected have had liver biopsies, but in the very early stages, or in the 80s and 90s, liver biopsies were quite frequently undertaken. And then they kind of fell out of, I wouldn't say fashion, but it was thought that they didn't really add terribly much to the management of the disease because the disease is patchy, and so the supposition as a biopsy isn't terribly helpful. But there's been recent data that actually histology is helpful, and histology, so knowing how much scarring there is in the liver is helpful in terms of predicting what somebody's outlook is from primary sclerosing cholangitis. And it then follows that if a biopsy is helpful, then trying to assess how much scarring people have in their liver by using non-invasive tests potentially offer benefits in terms of judging how severe an individual patient's disease is, but also what their individual prognosis is. So there's quite a lot of interest in using things like FibroScan. I think the machine was outside, and some of you may have already had a FibroScan, but anyway, so we use that now quite regularly, both in clinical management, but also for prospectively monitoring patients. We published something last year with a group from Oslo looking at blood markers of fibrosis, where we found that using a blood test you could predict to some extent the prognosis for people with PSC. And there's a lot of interest now in different MR technology, so MR elastography, and there's a new scan called Multiscan that's been developed by Oxford, which they're interested in looking at in people with PSC. So it is an area of interest in PSC, and it's an area of particular interest here. And I put this slide up just to demonstrate all the different sort of projects that we're working on in this area of staging of disease and prognosis, and how some of these projects are projects that we're running from the Royal Free, but also that some of these are collaborations with other big PSC centres in around the world, like Paris, who were the ones that first reported the value of FibroScan in PSC. They're now doing a prospective study that we're involved in. As I say, we collaborated with the group in Oslo for this ELF test. And then we're trying to develop some disease-specific biomarkers in PSC, so taking blood from people with PSC and looking for specific markers of fibrosis turnover in people with PSC, and developing tools out from patients with PSC, and also by taking liver biopsies and also explanted livers from patients with PSC, trying to break down the fibrosis and analyse the fibrosis, and then get a better picture of what patterns of fibrosis people with PSC have, to try and think of other tools that we might use to monitor people's disease or stage people's disease. So it's an area, as I say, it's an area of particular interest in the unit here. So the next thing is about these sort of surrogate markers, or we're getting to the point where we better can judge how severe patients' diseases are, but how do we assess response to treatment? And that's still a problem. I've mentioned the idea of transplant-free survival. That's obviously the sort of optimal gold standard in terms of an outcome in a trial, but it's unrealistic to follow people for 10 or 20 years on a drug to see if the drug is effective. We need things that are going to tell us more rapidly than that. There's also, we've mentioned a little about symptoms. It's a value to develop treatments that are good for the symptoms of PSC alone, even if they don't improve the natural history of the disease. If they make people better, then that is a goal in developing treatments. But one of the problems is we don't really have a tool for measuring the symptoms of PSC and comparing it amongst different patients, and also monitoring it in individual patients over time. So what we really need is a tool that will be that is kind of validated for that reason, and I'll say a little about that. And I guess the best treatments are ones that are going to improve outcomes and make people feel better. So short of looking at transplant-free survival, there's other, we're having to find surrogate markers, and most of those are things that I've mentioned earlier. And at the moment, the two most likely ones are looking at the response of alkaline phosphatase, so looking at someone's alkaline phosphatase level before they go on treatment and after they go on treatment, and if it falls, then that is a response, and we predict that that should be associated with an improvement improved outcome. And the other thing is, if a liver biopsy shows improvement or favourable change over the time that somebody's on treatment, then that is probably indicative of a response to treatment. So those are the two favoured sort of endpoints at the moment, but there's a lot of work that's still being undertaken to see if we can get better endpoints than that, or endpoints that are more indicative of a favourable clinical outcome. And at the moment, we're not quite there. So just to mention the quality of life project that Martine mentioned. So as I say, there's no tool for evaluating quality of life in PSC. There have been several publications, probably about 10 or 12 publications reporting quality of life in people with PSC, and all of them use non-validated tools or tools that have been developed for other liver diseases. An example of that is this PBC-40 tool, which was developed for patients with primary biliary cirrhosis. So in collaboration between ourselves, the British Liver Trust, PSC Support, and researchers in Birmingham and Newcastle, we've secured £100,000 of funding from the British Liver Trust to start this project. And that will fund a PhD student who will undertake this work over a period of 3 years. And the plan is to develop, evaluate and then validate a PSC-specific quality of life tool. And for all the reasons that Martine mentioned, this will be an enormous step forward, because we will then be able to monitor patients' quality of life. We'll also be able to, in trials of new treatments, assess whether a treatment might help people's disease, but it may make people's quality of life worse, or it may improve people's quality of life and have no impact on the progression of disease. But at least we'll have some means of measuring that, and I think that's a real need. And I would expect that within a few years we should have something that will be very helpful to be used in these prospective research studies that I'll go on to talk about. So what about new treatments to be evaluated for PSC? Well, as you know, the treatment options are limited, to say the least. We've got treatments for itch, we've got treatments for episodes of cholangitis, fatigue, which is obviously a very common symptom we don't have any effective treatments for. And then the question of treating the underlying disease. Well, I think we're unlikely to get any more evidence about Urso, and you can draw your own conclusions, and you may have had lengthy discussions with the doctors about the benefits or otherwise of Urso. I think what you can say in low or middle doses, sort of 13 to 15 milligrams per kilogram, it's probably up to 20 milligrams per kilogram. Probably it's not harmful. It probably improves, or it does improve liver function tests, but there isn't really much evidence that it does much more than that. So we really need something beyond Urso. There is some evidence for undertaking ERCP, which is an endoscopic procedure to treat strictures in the bile duct. If there's one stricture in the bile duct that's very what we call dominant, so it seems to be one stricture that is causing a blockage in the bile duct that needs to be unblocked, then there's evidence that if you unblock that it helps the situation. There's even some evidence from uncontrolled trials that doing that might actually slow the progression of disease, but that is somewhat controversial. But when we do an ERCP, it's not clear whether we should be trying to stretch up those narrowings or whether we should be putting a stent in, and if we put a stent in to unblock the narrowing, how long we should leave that stent in for. So one of the trials that's ongoing at the moment is a trial that's been run from Amsterdam, which is being run across Europe. And it's looking at people that have these dominant strictures who present with jaundice or other features to suggest this stricture is of significance. And then it's a comparison of putting a stent into the bile duct for a couple of weeks to deal with the narrowing, or undertaking a balloon dilatation and then leaving no stent there, to see whether one of those two approaches is better in terms and the outcome is being assessed by looking at how many people have no recurrence of problems with that stricture 2 years after the procedure. So that's one clinical trial. It's only relevant to the 10 or 20% of people that get problems with dominant strictures in PSC. I think we're the only centre in the UK that are participating in recruiting patients into this trial, and we're very open to involve any patients that would be interested in participating or taking part. But as I say, it's really for the minority of patients that it's suitable. So in terms of new medical therapies, there's really 3 areas that are being considered as areas where treatments might be effective. And so this is a liver biopsy from somebody with PSC. And this is a bile duct here. And what you can see is a very damaged lining of the bile duct. And that's surrounded by fibrosis, and this is the so-called onion skin fibrosis. So if you imagine you cut through an onion and you get these layers of fibrosis around it, that's what this appearance here is called. And the other characteristic feature of the pathology in primary sclerosing cholangitis is this inflammatory infiltrate as well. So the 3 targets that are being considered at the moment for treatment are treatments to protect the damage or protect against the damage of the lining of the bile ducts, and that's looking at bile acid therapies or therapies that interfere with bile acids. The other option is to look at treatments that prevent the development of fibrosis. So I've already mentioned that fibrosis is important in terms of the progression of the disease. So if you can prevent fibrosis, then potentially you can delay the progression of the disease. And the third approach is to look at treatments that interfere with the immune the immune response that is generated once the initial damage occurs to the lining of the bile duct. And that immune response, the outcome of that immune response is the development of fibrosis. So if you can stop the immune response, then you will also have the effect of preventing fibrosis developing, which will prevent the disease progressing as well. So what sorts of people with PSC can be involved in the trials? So this isn't the entry criteria for any one of the trials, but it's an outline of what the entry criteria generally are, and with a bit of variation. So they're always for men and women. They're always for adults, so there aren't clinical trials for younger or older patients at present. The PSC has to be diagnosed by the standard diagnostic criteria from the European and sort of international guidelines. Because alkaline phosphatase is often used as a measure of response to treatment, then usually the trials only include people where the alkaline phosphatase level is high at the time that somebody is being approached about being involved in the trial, so that there is some way of measuring the response. So a high alkaline phosphatase is pretty well universal in the trials, or a requirement to be involved in the trials. They also aren't looking for people with terribly advanced disease, because for the reasons that I mentioned, that some of these treatments we would expect may be only effective in the early stages of disease, and therefore if you wait to people, or if you test these treatments on people with too advanced disease, it may be the disease has already progressed beyond the point where these treatments will be effective. So usually it's people with lowish bilirubin, so bilirubin levels that may be slightly elevated, but not high enough that they would be obviously jaundiced. And that's pretty standard for the trials. In terms of the use of Urso, well, because of the controversy about whether Urso is an effective treatment, They don't exclude people that are on Urso, and they don't exclude people that are not on Urso. But the important thing is that the dose has not changed for a period of around 3 months before people are recruited into the study, so that any changes in the results are not due to any change in the dose of the Urso. If people have inflammatory bowel disease, again, the important thing is that the condition is stable. You can have, in remission means effectively there's no symptoms or very mild symptoms, and the important thing is that people are on stable treatment, that the treatment isn't being changed a lot in the period leading up to the trial, because again, that may muddy the water in terms of the response in the clinical trial. And then more recently, there's been some inclusion of non-invasive assessments of fibrosis. And the reason for that is, again, to try and exclude people that have got advanced disease, because it may be in that group of patients that the treatments may be less effective. So they're wanting to look at patients with milder disease. So that's one criteria that's gone into some of the more recent trials. So that sort of outlines the sorts of people that can be involved in the clinical trials. And actually, from doing seeing people with PSC in clinic, actually that includes a lot of people with PSC. So in terms of the actual treatment options and the trials that are open or are underway at the moment, there are 4 trials of looking at bile acid therapies. This one is a kind of son of Urso. And that trial closed, I think, last year. And the results are due to be reported imminently, I think. If that is successful, it's likely they'll go on to a more advanced phase study. So a phase 2 study is a study that's primarily looking at safety with a little bit about whether it's effective or not. But the first thing is to establish whether it's safe, and then the efficacy is assessed usually by some kind of biochemical surrogate marker like the alkaline phosphatase. This study was a phase 1 study of a drug originally from Lumina, and Lumina were bought out by Shire, and this is a drug that inhibits the absorption of bile acids in the gut. So the idea was that it interrupted the circulation of bile acids, and by reducing the amount of bile acids in circulation, if the bile acids are causing the damage to the lining of the bile ducts, it should protect against the development and progression of the disease. And that study just closed a couple of months ago. We were involved in that, and so the period of treatment was only 3 months or so. So I would expect the results should be available in sometime into the springtime of next year. You may all have heard about obeticholic acid, and certainly been gaining a lot of attention in terms of the trials looking at it for primary biliary cirrhosis. And it's likely to get licensed for PBC in 2016. There's a trial looking at it in PSC, which has opened in the US and was due to open in Europe as well, but they've hit regulatory hurdles, and I think the regulatory authorities in Europe were expecting them to make very significant changes to the design of the trial, which Intercept were not wanting to entertain. So that study is now just going to be open in the US and will not be open in the UK. There's another drug produced by Novartis, which has a similar characteristics to obeticholic acid, and in fact is a more powerful so-called FXR agonist. And it may be that there'll be a trial of that in primary sclerosing cholangitis, but to my knowledge, that isn't in development at the moment. But I expect we'll hear more about it. And the final one is this trial that's going to be opening shortly. There'll be 4 or 5 centres. I don't know exactly how many centres, but I think they invited several centres from the UK to participate in. And this is a treatment which has similar effects to obeticholic acid. It's different. It's a so-called FGF19 analogue. and I'll say a little more about that. So these treatments all interfere. I'm not showing this for you but they basically, there's sort of mechanistic reasons why these agents are being considered to be appropriate drugs to try in patients with PSC, because they interfere with various steps in the pathway of bile acid recirculation and bile acid homeostasis within the body. So in terms of this MGM 282 study, that will be opening soon. It's a trial, a randomized trial, where people will be there'll be 3 groups. I think there's a total of 60 patients, so there'll be 20 patients on each of these treatment arms. Some receiving placebo, some receiving 1 milligram per day, some receiving 3 milligrams per day. The drug's administered by subcutaneous injection on a daily basis, and the treatment courses for 12 weeks, and then there's 4 weeks of follow-up after the treatment stopped. And there's frequent visits, obviously, during the course of the study. And as I mentioned, in terms of an endpoint, the endpoint that's been selected for this study is the change in the alkaline phosphatase level in 12 weeks, plus all the safety monitoring, etc., that you would anticipate. So regardless of where you're being looked after, you may hear about this. I expect on PSC support there'll be significant information, and there'll be an opportunity to be involved in this trial. In terms of I'll mention antifibrotics briefly. There's one antifibrotic a trial of one antifibrotic. It's an antibody treatment against LOXL2, cemiplimab, I think it's called. The study closed, I think, earlier this year, end of 2014. It's a 2-year study, so I expect it'll report in 2016, 2017, but there are no further studies of antifibrotics at the moment in PSC, but wait the results of that one with interest. So the other treatment targets are looking at the immune, trying to target the immune response. And there's 2 treatments that are that are 2 trials that are looking at this area that are open soon, open now or opening soon. The first one is a treatment called vedolizumab, which is now NICE approved for the treatment of inflammatory bowel disease. And that trial's been in the offing for over a year, and everything fell silent. But in the last few weeks, it's clear that they're planning to take this trial forward. There's some evidence from the IBD trials that it's not harmful in people with PSC, but the question is, does it help people with PSC? And then there's this other trial that's being run. It's a small company called BioT from Finland make this agent called BTT 1023, and the trial's being sponsored by the University of Birmingham, and it's a treatment that inhibits VAP1, the VAP1 receptor, and it's being run on 3 sites, Birmingham, Oxford and Nottingham. I think Nottingham are open. I'm not sure that the other 2 sites are open as yet, and they're looking to recruit 50-odd patients. But Birmingham are both open as well. Nottingham and Birmingham are open, but Oxford isn't. Yeah, okay, thanks, Martin. And again, not to kind of labour the point, but these drug treatments are, the way that they work is to try and interrupt the mechanism by which inflammatory cells target the liver. So when inflammatory cells are moving around the body, there's something about the lining of the blood vessels in the liver that allow those inflammatory cells to bind on to the lining of the blood vessel and then move through the blood vessel wall and into the liver tissue where they cause damage. And what these treatments do is try and interfere with that process to prevent the inflammation from focusing within the liver. And so the vedolizumab acts by binding on to here, and the buteo treatment, or this treatment in the Birmingham study, interferes with this VAP1 receptor, which is necessary in this process, which allows the inflammatory cells to kind of hone in on the cells lining the blood vessels in the liver. So there's good rationale that these treatments may be effective. The question is, are they? And so these trials are underway. So in terms of the vedolizumab study, there's about 270 patients. It's a randomized trial. So there's 3 groups, one receiving placebo, and 2 groups receiving vedolizumab at the same dose, but one at 4 weekly intervals and the other at 8 weekly intervals. All of the people that will be recruited into this study with PSC will need to have IBD, and the follow-up is over a period of around 2 years, so it's 106 weeks and then a period of 18 weeks follow-up. And the endpoint in this study is histology, which means that for people to be involved in this study, they'll need to have a liver biopsy before they start treatment, and they'll need to have a liver biopsy at the end of 2 years after being involved in the study. And that obviously is something that would be in addition to routine care. And so the interesting thing would be to see how many patients are interested in participating in such a study. And then this is the Buteo study, the study from Birmingham. This is a single arm, so there's no randomized, there's no placebo arm to this study. Everyone's getting treatment. It's given by infusion, intravenous infusion. It's given every 2 weeks, and people receive 7 infusions, and there is the opportunity to try higher doses. The period of treatment is just under 80 days, and then there's follow-up around 40 days. The endpoint is to look at the changes in the alkaline phosphatase level, so it's it's the change in blood tests, and also the safety, efficacy, and tolerability of the treatment. So there's quite a lot of studies that are either underway or open, and the ones that I've highlighted in red are the ones that you should be trying to keep an ear out for, and maybe asking the clinicians that you see whether there's a way of getting involved in if you're interested, or going via PSC support, finding out where the centres are, that the trials are open should you be interested in participating. I think the 5 centres that I outlined earlier on as the hub centres, I expect will be running these clinical trials. Some of the trials may not be open in all of them, as is the example with the Buteo study, which is only open in 3 of them. So I think what I hope I've shown you is that there's a lot of progress, that there's a lot of research going on, that I don't think we've answered these questions, and I don't think we've not kind of closed the circle, but I think we've made great strides. We're trying to break the condition down into component parts, trying to understand the nature of the disease, trying to, from first principles, working out what treatments might be effective, and then trying to look at them in well-designed trials. The final thing I was going to mention was that another area of interest that we have at the Royal Free, which is not something that's being addressed, I think, through the UK-PSC study, and I think there's some posters outside, but Steve Pereira, one of my colleagues, has a particular interest, is bile tract cancer. And so we're looking at various aspects of biliary tract cancer and biliary tract cancer in primary sclerosing cholangitis. So I think we're probably the only centre in the UK that have a particular interest in that area. So it was just to highlight that as well. And all the work that's done here is the product of many individuals, clinicians, scientists, and we have a specialist PSC and autoimmune clinic that we run on a Monday afternoon, where we try and biobank from all the patients that are attending, and we give the patients the opportunity to hear about all the clinical trials that are opening. We do the prospective FibroScan monitoring of patients. But that really is a multidisciplinary effort of nursing staff, medical staff, and scientists. So it's just like to thank all my colleagues who work with us here to try and help things move forward with PSC. So I think, in summary, I'm sure you all know, I don't need to tell you that there's a large unmet need in PSC. But with the formation of these large consortia, both within the UK and around the world, it really provides an opportunity to try and answer some of these very fundamental questions in our understanding of the disease. That within the UK, that over the next year or two, these PSC research hubs are really going to be gathering momentum. And through those sites, you'll be able to access clinical trials should you be interested. Thanks very much. Thank you.